ahead and get started. Hi, everyone. My name's Jen Goldsack. I'm the CEO at the Digital Medicine Society, or DiMe. For folks who may not know DiMe, we are a global nonprofit dedicated to advancing the safe, effective, ethical, and equitable use of digital technologies to optimize health. I'm delighted to welcome not only a formidable panel to lead an important discussion to the line today, but also all of you who have dialed in. We are very proud to be partnering with our colleagues at the Consumer Technology Association, or CTA, to maintain some of the important conversations that started at CES this year. CES was a landmark year in 2022. For the first time, we had a large medical device company, our colleagues at Abbott, took the stage for a very compelling keynote, really underscoring that at this point, as digital innovation matures, as do consumer technologies, that there is an enormous opportunity and, quite frankly, some new risks that we'll talk about today at the intersection of these two fields. I am very proud of the commitment between the Digital Medicine Society and the Consumer Technology Association and the communities that we serve to continue these important conversations, to be good stewards, that as we bring forward the promise of digital innovation to improve lives, we are doing it intentionally, and we are collaborating, and we are bringing the best minds to drive this innovation. And with that, I will introduce our topic for today. So today we will be discussing bias in the evolving landscape of AI in healthcare. But before I go ahead and introduce our panelists, I do want to orient all of you on the line to how you can participate in this important conversation. So, and I think I may have missed some housekeeping slides. Here they are. First of all, full disclosure, we are recording today's session. That does mean that slides in the recording will be available later today via the website if you would like to share that with colleagues who can't attend. We also will be leaving time at the end of our session for a question and answer period. So there's a couple of ways to participate in that. As we go through the conversation, please feel free to drop questions or comments into the comment box or into the Q&A function, whatever you feel more comfortable with. We'll be monitoring both. As we get to Q&A and as our experts wrap up their conversation, there's also the opportunity to ask your question live. So please feel free to raise your hand when it's time to do so, and we'll call on you, as we said, to pose your question directly. So with that, we're delighted to kick off this series with our conversation around addressing bias when it comes to deploying artificial intelligence in healthcare. And Amy, I will hand over to you as our moderator for today to introduce yourself and this really extraordinary team of women, I want to underscore, who are leading this important conversation today. So Amy, you have the floor.
Wonderful. Thank you so much, Jennifer. It's an honor to be here with all of you today, both the panelists, and I'm seeing many friendly names in the audience, and hopefully to have a really robust discussion. So again, like Jennifer said, please feel free to join in and to comment along the way, as well as during a question answer session at the end if something comes up. I'll just introduce myself quickly, and then I'll have our speakers introduce themselves as well. My name is Dr. Amy Putt. I am a cardiologist at the Massachusetts General Hospital and a professor at Harvard Medical School. And most recently, 3 weeks ago, I took the position of Chief Innovation Officer at the American College of Cardiology. Very excited for the work that we do there, but really excited for the partnerships. And so grateful to CTA for having brought us into thinking about where is health tech going, what do we need to focus on, and how can we break down those silos of how we're all involved in health in our own different areas. And I think that's one of the great things that CES has done for us, and that DiMe has equally done for us, is bring all these different types of people together. So I hope you see that in our panel today. So maybe we will start, and we'll have Sarah Awan introduce herself first, then Milissa Campbell, and then Carol McCall, if that works. Sarah?
Absolutely. Thank you, Amy, and thank you to DiMe and CTA for hosting. Hi, everyone. My name is Sarah Awan. My pronouns are she, her, hers. So I'm currently a senior manager at CEO Action for Racial Equity, which is a business-led coalition advancing racial equity through public policy. I lead one of our policy areas, which is around how to narrow the digital divide for Black students and families in the United States. But before I transitioned into sort of corporate philanthropy a couple of years ago, for 9 years, I'd been working in leading digital innovation teams at IBM, at PwC Digital, and then a Microsoft and Accenture joint venture company called Avan. And really my day-to-day work was around, helping our clients across various industries, healthcare being one of them, to help leverage data and technology and tackle some of their pressing use cases and concerns that they might have. And alongside my work, I'm also a practice fellow at the Cambridge Centre for Social Innovation at the University of Cambridge, where I look at how AI and machine learning can perpetuate gender bias.
Lovely. Thank you so much, Sarah. Milissa, over to you.
Hey, thank you so much. So Milissa Campbell, I am a managing director at NTT Data Services, and I lead our health insights team. So my team is responsible for driving anything to do with data-driven health with our clients who are typically health systems and health plans. And so grew up in the industry, so I've been on the other side of this consulting table for several years and just watching analytics grow up for the last 30 years, right? And how we're using it in healthcare and how are we leveraging the other industries who are unfortunately ahead of us on this journey. How do we leverage their learnings and their expertise to do better over in healthcare? So I spent some time at Accenture. I can't believe Sarah and I didn't cross paths, usually when you're in the same space, but happy to be here and excited to talk about what is really an important topic.
Fantastic. And Carol McCall.
Thank you. Good afternoon, everyone. Really excited for this session and the conversation with such a stellar panel. My name is Carol McCall. I'm the Chief Health Analytics Officer for ClosedLoop.ai. We're an Austin-based startup that has created the industry's leading healthcare AI platform. A little bit about me. I'm a health actuary and population health executive with about 30 years in the industry. Expertise includes health economics, health services innovation, health informatics, and AI. And if I had to characterize my superpower, I'd probably say it was integrating all of these in ways that help us rethink some of our traditional notions of care and help create sustainable, value-driven, and equitable business models. A little bit about Closed Loop. We support some of the leading companies in value-based care, and this includes organizations like Southwestern Health Resources, Ochsner, Medical Home Network, and we were also awarded, best in class for healthcare AI this year in 2022, and last year won CMS's AI Health Outcomes Challenge. And that last achievement, I think, is particularly relevant for today's webinar. The challenge was really more than an accuracy contest, and CMS set a pretty high bar. And to win, basically, participants, in addition to being accurate, they had to create what CMS called AI that physicians could trust, and they had to demonstrate how they would go about identifying and addressing algorithmic bias in healthcare AI models.
Wonderful. Well, I think that kicks off this conversation really well. Let me just give a little bit of framing to where we're going to go today for the audience. When we first started this discussion, part of the thought between the American College of Cardiology and the CTA was, what are the issues that are really pressing? And we both landed on two ideas. So the first is that algorithms and AI are going to be extraordinarily important. And as Carol likes to say, and I don't want to steal her thunder, but she was the first one to say to me, if you don't already have it, you're already behind, right? And it's there, and we have it amongst us. So as a clinician, one of the important things that we recognize is there is a lot of burnout and there is a lot of data, whether that's data that's coming from a patient because of ambient collection or wearables or other information, whether that's remote monitoring devices, whether that's the EHR or additional information that we can get that may not be included in that about our social determinants of health. It is very challenging for a single clinician or even a team of clinicians to be able to take all that data and make sense of it. And for us to provide the kind of level of quality of care based on data and science and how far we've come to get to that quality of care, we need a new foundation and then use our clinical acumen on top of that. And that's what all our different silos have been moving towards and where we've finally come. So with that in mind, we wanted to be able to talk about how algorithms and AI are important. And the first thing we realized is we need to think about what's going into them. We need to think about everything ranging from data standards to reassessing, to how we actually build the data, to how we monitor it long term. And therefore, this exquisite panel that we brought together of people who can actually answer those questions, because we as clinicians spend a lot of time asking those questions. And so really excited for this today. So maybe we should start to level set. And the first question we had in mind is, what is algorithmic bias in healthcare? And how does that manifest in practice? And so maybe, do we want to start with Sarah? Do you want to start with chatting a little bit about how you see that? And then we can go around.
Absolutely. So algorithmic bias really is the application of an algorithm that compounds existing inequities. And that might be in socioeconomic status, in race, in ethnic background, religion, gender, disability, sexual orientation, etc. And it amplifies inequities in health systems. So while AI biases, AI can help identify bias and reduce human bias, it really also has the power to deploy bias, at scale in very sensitive application areas. I'm sure, most of the panelists will talk through this, and I'm sure the audience knows that, algorithms are sort of being used across the board. It's not just about who should get access to healthcare or insurance or what premiums a patient should be paying, but everything, along the lines of reducing costs. So that might be improving healthcare outcomes or improving a patient's, patient experience. Then there's a whole other category of algorithms and how they're manifesting in practice, which is around risk mitigation. So to assess risk, to categorize people based on some type of risk, and whether that might be something as small as not showing up to a doctor's appointment, or will a patient adhere to, prescribed medication, to the risk of developing a chronic illness, the following year. So I see risk mitigation use cases are usually primed for artificial intelligence of some kind. These algorithms learn from historical data, they learn the patterns of people's behaviors, how diseases progress, and then sort of predict what a particular outcome might be.
Right. So Milissa, if we're then kind of looking at this, there are a lot of different challenges to be addressed in healthcare. And you guys think about this a lot. Why this? Why now? Why should this be the top challenge? That may be a question that comes up to many of you. Any thoughts on that?
Yeah, absolutely. And I love what Carol said at the beginning around, or your quote of Carol, which was basically, if you don't have it, you're already behind. And I find that to be an interesting balance in the health industry. Again, in data and analytics, as an industry, there are pockets of innovation, but as an industry, we tend to lag other industries in data and analytics advancement. And it's unfortunate. It's probably one of the more important ones. So I think that these pockets of innovation are spreading rapidly and we're getting there, but the challenges really face from the entire, don't focus on the challenges of your model. It's your model and your data, how it's collected, how it's ingested, how it's right. And then it's the other going forward on the value chain, which is how it's trained, and thinking about data sets that are non-standard and you wouldn't think to put into a model, but let the model tell you what's important, right? So really thinking and having a framework and a governance around not only your data governance, is a well accepted, but your models and how you're using that data, and some transparency and some governance and a framework around that is probably the first and foundational thing that we really address with clients. And also having a vision to move to AI should absolutely be your vision. You should already have your plan and your roadmap and be working on that, but address your foundational challenges first, right? Because it is any of us who've done any work in analytics will say garbage in, garbage out. So address your foundational principles first with a vision towards moving to a very unbiased, ethically managed AI approach.
I love that. Address your foundation first, right? So important. We're kind of excited and rushing towards things, and you recognize you have to really know where you've started. Carol, you've put both of these concepts into action,
right,
with closed loop AI. So maybe before we get into the as still part of an intro to this concept, when you were setting up closed loop AI, what did you think about in terms of what the governance would look like? What are the best practices for maintaining and using algorithms that you then introduce to health systems to be able to do this?
Yeah, I think before I jump into that, I just want to reiterate kind of your question of why now. And I think that it's absolutely vital that people jump on this now. They can't delay. And the reason is because a big part of what I think we said it before, but algorithms are increasingly at the heart of healthcare, right? And a big push of that, because the big push of value-based care is into these alternate payment models, but to succeed under those payment models, organizations have to increasingly turn to an AI-powered solution to achieve better outcomes. And so the problem is that if those algorithms are biased, the organization can actually end up inadvertently exacerbating the very disparities that they are, hell-bent on trying to actually get rid of. And so they have to pay attention to it now. They can't do it after they get all this value-based care stuff in place and go, we'll come back to it. They will have actually likely made it worse. And so as we have worked with some of our customers, I think one of the things is noting you have to know how bias creeps in, right? And I think it can come from multiple places, right? It can, broadly speaking, there's kind of two sources. You can have biased data and it can be biased from multiple reasons, but you can also have what's called a biased label. And what experts have shown is that it's that second instance that is often the culprit. And a biased label means the label is a data science term for what's the thing I'm trying to predict. Am I trying to predict like a hospitalization? Am I trying to predict future risk? And what's happened is that people often use a proxy for that. And the proxy that has most often been used in kind of traditional first generation models was cost. And cost, while it's correlated with somebody's health status, it is not the same as somebody's health status. And there are a whole bunch of reasons why cost, so Melissa's going, yep. Why costs are higher or lower for reasons that have nothing to do with health status. And not only that, they are higher or lower for things that are strongly linked to health disparities. For example, the same procedure, if you pay for it under Medicaid versus Medicare versus a commercial contract, commercial contract may pay $1.30, Medicare will pay $1, and Medicaid pays 70 cents.
Right.
And so machine learning works, right? And it will learn that Medicaid people and the characteristics of people associated with people that are on Medicaid cost less. And if you use future cost, even if it's accurately predicted as a proxy for illness, you will be biased. And that was the thing that was discovered, in this widely publicized situation with this algorithm used by Optum. And it was largely driven by having a biased label. So what we do in working with our customers in terms of best practices, we use data that is representative, right, of the population. We try to build as many diverse and clinically relevant features as possible. We avoid cost as a proxy and try to get to as close to the thing that we're actually trying to predict, because the program is designed to address that thing, right? And we also test multiple proxies. We specifically measure bias, right? And so we have tools and methodologies that can help you assess the extent to which it's present, and those very same measures can help you change your enrollment criteria to help mitigate it. And we always monitor, because something that started out fair, unbiased and fair, we'll get back to that, it may drift. And so we have mechanisms that allow us to constantly monitor if something's drifting off course. So that's what we do.
That's fantastic. I think that lays a perfect groundwork for why and for best practices. Jennifer is commenting that at DiMe, they also really think about the time to digital innovation and how they are thinking about the data along with the AI really upfront, early, before things are set up. Two things come to mind. It's interesting. One is you say cost, and Melissa shakes her head. From a clinical standpoint, that's like when we say readmission, and we assume that somehow is a thing. Whereas, the number of things, and Sarah knows, the number of social determinants of health that go into whether or not somebody came back and used an ER or were admitted are maybe even greater than some of the cardiac issues that we look at. So I think it's a great point about what we use as a proxy, and getting to the description of what it is that we're really solving for.
And actually, I wanted to, before you move on, actually, what we're seeing in industry is up to 75, even 80% of a person's cost is driven by their social determinants of health. It's not in their claims. It's not in their diagnosis. It's not in their EHR. It is a very, very, very large number that's driven by the social determinants of health. So if that's not part of your model, you've uninformed your model, right? You've introduced a whole lot of bias. So when Carol was saying that, that's just something we're finding is more significant than I think we expected.
So maybe can we go in that direction, Sarah, for 1 second, since we're on this topic? People find it hard to figure out how to get social determinants of health into their models sometimes, and what researches they have for that. Others worry whether or not using social determinants of health are a way of biasing data. Can you just address a little bit kind of best practices in SDOH and thinking about that as we build our data?
Yeah, absolutely. So I guess just to echo what Carol was saying earlier in terms of making sure your data samples are accurately reflecting the population you are designing your algorithm for. I mean, the social determinants that I work with sort of on a daily basis are things like broadband access, broadband affordability, adoption barriers, and digital literacy gaps, which are 2 times higher amongst Black Americans than their white peers, and making sure that really account for these types of variables in the data set. So those are some that we work with every day.
Right.
I think too, not looking for social determinants of health. That's what I advise our clients to, right? Don't go say, let me find the people who live in a food desert. Let me go find the people who, right? It's let the data tell you something that then can be classified as a social determinant of health. I think too often we go, okay, we need to go look and make sure we have all our social determinants of health represented. You right away have skewed yourself, right? So go in the other direction, see what the data is telling you, see what you're learning, and then start working back towards where the social determinants of health drivers of that. And I think that's, you only know what you know. So
right. To add on to both of those, for the models that we build in adding data, one of the things that we do is because social determinants, data around the social determinants of health isn't easy to get, right? It's tough to acquire. We actually have some things built into our platform where we've taken publicly available data sets that are really, really elegant. It could be, the social deprivation indices or area deprivation indices. It could be the county health ranking information. There's a really wonderful data set called the Childhood Opportunity Index. And all of these data sets, they amass, tens up to, more than 100 different very specific variables. And what they do really well is they describe not a person, but they describe the context in which a person lives, right? So they truly are those social determinants. And so we add those they become variables available to the model. And it's amazing how the way that we build a model, we don't just produce a score, we produce what we call explainable AI. So we kind of show our work, just like our math teachers told us to do. And it shows all the variables that lead to a prediction. And what you see is all of these variables popping up and contributing really significantly to what we call a clinical outcome, like a readmission. But in a readmission prediction, you'll see a lot of SDOH variables being very highly ranked, in terms of the degree to which it's contributing to somebody's risk. And we also have customers that bring, say, survey data from an individual patient or beneficiary. And so that adds to it because that's actually talking about the person, not the context in which they live. The other thing that I thought is important to talk about is when we did the CMS challenge, we actually consulted with experts and looked at expert kind of publications on whether or not to include race in an algorithm. Because it's actually, first of all, there are times when you should and there are times when you shouldn't, and excluding it doesn't even guarantee that you're going to avoid bias. Right. Optum's algorithm did not explicitly include race or ethnicity, and it was biased, right? The second is that keeping it out isn't always best, and there are times when excluding it can actually do harm. And so experts, what we found is that they recommend asking 3 questions of your situation. And the first one was, is the need to include, say, race, is it based on like a robust statistical analysis, number 1? Number 2, is there a plausible causal mechanism that justifies its inclusion, yes or no? And then third, does including race in the model relieve or exacerbate health inequity? And you have to wrestle with those things, each one of them. And in our case, using those questions as a guide, we included race and ethnicity in our CMS models. It improved the accuracy for everybody. It's now broadly accepted that the social determinants of health are causal, with respect to disparities, that racism in this country actually has led to things. And so excluding them, kind of went against that second question. And removing it would have actually exacerbated health disparities, because we found that using our measures of bias, but also fairness, excluding it would have meant that more, say, whites and Asians would have been enrolled in care management programs, than Blacks and Hispanics and North American natives. And so, not that these models were actually used, but had the ones that we submitted for the contest been used, had they been used on their face, they would have led to inequities. And so, but we were able to demonstrate all of that. But those questions were incredibly valuable in guiding, very thoughtful conversations about whether to include or exclude, certain variables.
The point is well taken. So 2 and 3 that you just mentioned, I think 2 things. One is, I love the thought process of making sure we're not worsening inequities, or will we improve things.
Right.
Sometimes you can conjecture that. Other times you have to be willing to iterate. You have to be willing to say, did I do this? Quickly look, not working the right direction, move on, a little bit bigger. When I expand, now is there something different? And so I think that the importance of iteration cannot be understated there. We have a great question actually from the audience. Julie Reeder is asking, can you give your definition of social determinants of health? Sarah, maybe I'm looking at you. This is often confused, says Julie, with individual patient level social needs. So I think this is a good time, thank you, Julie, to level set on what we're talking about, because it is a range of things.
So from my perspective, a social determinant of health is sort of looking at the daily life of your patient. So what type of environment they are going to go home to. If they've come to a hospital for certain care, sort of when they get home, everything from, because my work is more technology focused, it is sort of understanding, like, do we have a good understanding of how they're interacting with the healthcare system? Are they digitally literate? Are they able to make a telehealth appointment? Is that available, accessible within their area? So for me, it is looking at sort of the social conditions of an individual in which they go home to.
Right. I would just add, I think this is such a vital question. And I think we slide from one distinction that Julie made to another, and we tend to commingle them. There's a context in which people live and the circumstances that they face every day. And then there are things about the individual, the risks that are about them as opposed to the context. And when we blur that distinction, what I find tends to happen is that everything becomes an attribute of the individual as opposed to the context in which we live. And then it's a very short jump into it being somehow either unpatriotic or a moral failing, as opposed to, it's not about me, it is my environment, right? And I think those are really, really important distinctions. And so I thank you for bringing that up.
And I think it's important to think of the social needs of an individual are a small piece of a bigger social determinants of health context too, right? So I think that's, while there's a distinction, it's also, there's a relationship. I don't want to say correlation, that implies a data connection, right? But there's a relationship between those things that at least can't be ignored. So I think social determinants, I love the context framework. I think that's a really great way to keep it straight in your mind.
Right.
So a comment and then another question from the audience. So I think one thing that we've often noticed through the ACC when we think about the communities that we're serving is the social determinants of health are not static. What social determinants may be relevant to your health now are going to change. And that's a little hard for the healthcare industry to get used to. Once you have a certain disease, you probably have it for life. It is a chronic disease. Your social determinants, whether that is individual level or community level, are constantly changing. And to incorporate that into these mechanisms and do the monitoring Carol was talking about, I think is incredibly important, because the ones that are important may change over your lifespan and affect your health differently. The question that we have from the audience is, if 80% of cost in health resides outside the EHR and outside of the existing purview of existing standards, do we need an industry framework for evaluating this for digital health, for wellness solutions? And so I will I will let you take that. I will also refer you, Ravi, and maybe somebody can put this into the chat for the audience, to the ACC CTA standards statement that just came out about using some of these wearables and connected health and other things that we do in the community. And so maybe we can pull that up and do that. In the meantime, would love to hear our panelists' thoughts on what's our industry framework for the stuff that doesn't necessarily fit into an EHR, or for that sake, I'll say a guideline.
So there's two questions there. There is the do we need one, and what is? The do we need one? Absolutely. And again, I think that ties in with the importance that it plays in the what is it? I think everyone's working to really figure that out well. Again, I think there's pockets of innovation that have started realizing a framework within which to work, right? I'm hearing Carol talk about a lot of things that I think are absolutely that right space. Yeah. But I think we've got to learn as an industry, and we've got to start aligning on standards and things that we agree as an industry that aren't just in the pocket of innovation, right? That are universally held as truths and get to that framework, because I do think it will hold us behind from harnessing the power of AI if we're not working within that framework. So the social determinants of health costs, right? The earlier question resonated very much. Are we talking about individual social needs? Or are we talking about social determinants of health, right? Part of a framework that starts really nailing down some of that taxonomy and understanding and building from that. So I think we need it. Yes. What is it? I think it's being defined, or at least being defined in a way that's universally agreed to.
Yeah. To add on to that, I agree that it is still, it's a work in progress. And I do see a lot of good progress, though, in terms of trying to come up with some of those data standards in terms of, so that it's not just a Babel fix and that we need to try to interpret what's going on. Standards in terms of how we are going to capture and characterize the data, not only about the context, but information that we're gathering from individuals. So both of those things. I also think that there is a growing awareness that the situation is bigger than healthcare. Just expecting healthcare, and the medical industrial complex to fix all of this is, if 80% of the causes are outside of healthcare, then it's not really within, their power. But having said that, I think the good part of a lot of the value-based care models is that it is inspiring, maybe for the first time, kind of dedication and investment in figuring out those causes of causes and trying to find innovations and solutions that reach outside the traditional notions of care. There's a lot of work and interest on the part of, community-based organizations and the whole, it takes a village. So I see a lot of innovations around trying to identify agencies and people that are already doing good work in a community and trying to make those links of people with resources, right? And so that's a lot of the effort that I see now. And it's some of it is really starting to have a real impact. And so I think more momentum around things like that and other things will come as well, are all to the good.
That's wonderful. I want to point out, Carrie, thank you, has put into the chat so that everybody can see the CTA standards on digital health, the CTA standards on AI and healthcare, and the CTA ACC document on best practices for consumer cardiovascular technology solutions. And Carrie has put her email in the chat for those who are interested in that, if they'd like to reach out and learn more. Lucas makes a great comment. He says, SDOH data is not standardized. It is based on sources a particular supplier uses and the ability to link the SDOH to the EMR or claims data. That has been an area where people have found things challenging. Maybe Milissa, can I look to you first for any thoughts about that and advice for our audience?
And I think that's a version of a variation on the label bias that we talked about earlier, right? Which is how you link the data is going to affect how the model reacts. And so, the challenges that we see health organizations struggling with is exactly that, right? But I think there's a concept, again, I know I'm latched onto it, but it's just been a great reframe for me, which is, yes, linking the person to the data is important, but we're talking about the context within which they live and versus their individual social needs. So if we start thinking in that lens about how we link the data, I think it starts being less intimidating and less, I think it feels more solvable, maybe is the right way I'm looking at it. And And so that's really that's kind of the tie that's resonating with me out of this conversation, which is it's a context, right? So making sure that when you're building your models, when you're training your data, when you're introducing your data, you're thinking about it through that context lens versus the individual person. And it doesn't mean there's not an importance to have links there, but just really thinking about, is that link the right link to make, and why, and what bias did you just introduce by answering those two questions?
Right.
Yeah.
And to add on to that briefly, it also means measuring context.
Yes.
Right. And so, there are a lot of things where, for all the data that we have, there are a lot of things in healthcare, or the things that promote health and health equity, that are poorly measured, if they're measured at all. Right. And one of those is all of these different contextual variables that as rich as they could be, that's where at the beginning of capturing the context, in which people live, eat, work, pray. So there's more to be done there. There's also more to be done to capture the outcomes that we really want. So a lot of the outcomes in the work that I see, they tend to be two things. One, they tend to be adverse events, right? And so we tend to look at avoidable hospitalizations and readmissions and ER visits and all these things that we don't want to happen. But what we're not capturing are things like degree of function, and things that we want to actively try to promote. And what it does is it makes it harder for us to actually assess whether or not our innovations are working, because we have to sit around and go through all of the complicated math to measure whether the things didn't happen, right? As opposed to actively promoting if they do. And I also think the other thing about measurement is that we are still stuck in what I call an ROI trap. Our time horizons are still very short. And we really need to see right now, we need to see returns of these events that we're trying to prevent. We look within a year's period of time, give or take. But what about the things that don't manifest in better outcomes for 5 years or 10 years? Or think about early childhood development, where there have been elegant studies done that if we invest in early childhood development, what you get in return is a human life that is dramatically transformed, but it's 20 years down the road. What about things like that? So I think there's a lot to be done still.
Well, Carol, I wanted to hash on that because that's one of the challenges as I start working with healthcare, as I work with health plans in particular. The tail on ROI is such a focus and a very hard story to tell. Add in there member churn, right? So sure, if I invest in this member this year, they're probably not going to be on my plan next year, right? So what benefit do I get from the investment that I made? The short-term ROI and lens versus a population lens, which is the better off our population is, the better off individuals are likely to be. And so, but that is probably one of the biggest challenges I face is trying to guide health plan organizations who from a one standpoint are committed to this concept, but limited by the very hard and fast ROI near term piece of it. And I think that's a struggle we need to figure out as an industry, or it will continue to be our Achilles heel.
It will. And the culprit there really are the business models. You could go into any industry and if it's not economically rational for a company to make certain decisions, they're not going to do it. Right. They simply cannot afford to. And so the solutions to this, really they live and breathe at that business model level. And because if you tell me how people make money, I'll tell you what they get up and care about every day.
Yes.
And so I'm hoping that a shift to some of the value-based business models in healthcare, that we can kind of elongate the period of time over which some of the economic realities play out. And so that we can make it more economically rational for companies to do what we know that they want to do. Everybody, wants to do this. There are very few bad actors here, and there is no them. So, but we just have to make it easier for people to have sustainable and successful businesses while doing these things. And that's just my inner actuary talking.
No, the inner actuary, I love it. So a few things that came out of this discussion that I just want to call out again. So first is we are talking a lot in healthcare in general about not being reactionary, but being proactive, right? And moving from doing more tertiary care to being actually preventive in our care. And that's where a lot of digital health and innovation is coming in. We've been very innovative in tertiary quaternary care over the past 2 decades. Science has done us good, but really now focusing on the data and how we can get things earlier. You're right. we are doing things earlier to prevent X rather than to say this was maintained, this was improved. And so I love that lens, and I want to just call that out to all the participants in the audience. Can you start to look at your own data and your own workflows with that lens and see what you can find? The other is the foot in each canoe, right? We here have a fee-for-service canoe and we have a value-based care canoe, and those canoes are still out there and they've been there for a while, and they're probably not going anywhere rapidly, and that's okay. But I liked what Milissa said with reference to what you said, Carol, which is the larger organizations, and I want to get to talking about those large organizations and fairness in just a second, right? Okay. But those large healthcare organizations do have a vested interest in population health. So while the individual is important to focus on, showing that the systems we're setting up can help population health is incredibly more important now and more recognized now than perhaps it was earlier in terms of business models outside of actually being a value-based care pure organization. So I think there is a place where even in the fee-for-service model, some of these other health systems do have things about population health that we can call our value-based model, if you will, for now, even if those individuals in it are in a fee-for-service model. And so I just want to throw that idea out there. We had wanted to talk when we had pre-spoken, I'm telling this to the audience, about the idea of what does a healthcare organization need to do now and plan for? What can we do as individuals, the people in this session? And I do see some of your questions, so I will get to them. But I wanted to talk a little bit about, looking at patterns emerging versus feeling judged that a pattern emerged. Can we talk about what we can do now to move forward? And I'm using a broad we because our audience has a whole lot of different people in it. Who wants to attack fairness first and what we can do now?
I'll start. I think, again, it's have a clear vision of what you're trying to achieve. And I think we've talked a lot about that today, right? It's the basic concept for anything we do. Have a clear vision of what you want, where you want to be, and why. And to Carol's point, what you care about when you get up every day, and then be sure that you're starting where you really are today and have a plan. This is not something that happens just, oh, this year I might work on it a little bit, and maybe next year. This is something that has a plan with a framework and rules of engagement and governance and and iterations. And I think a bunch of the words we said today. So it's about clearly vision what you want tomorrow to look like, clearly accept where you are today, and build an informed plan. An informed plan means connecting with all kinds of groups, 3 of whom are represented here in the panel, but all kinds of groups that will help you inform your plan so that it's one that has the highest likelihood. And then just go, measure success, pivot as you go, but we're taking a long time to think about it. And we're wanting to start in the middle of the journey. So those would be my 2 recommendations to organizations, which is keep talking about this, build your foundation, have a clear vision and a plan.
Sarah, thoughts from your perspective?
Yeah, absolutely. So this sort of recent discussion sort of makes me think around, in terms of counteracting bias, or how can we be best prepared to, tackle a problem like this? And from my perspective, I think every single person and or institution that's involved in producing the data, so in cleaning the data and building the models and deploying the models, making decisions on the models, share a part of that responsibility. But I don't want to understate the role that I think the technology sector and the vendors you're likely working with really play here. Like, I think, data scientists, machine learning developers, they really do have the power to sort of amplify which parts of our society we would like to see in these tools and technology and which parts we don't. So there's a great deal of responsibility, I think, that the technology sector should feel in not perpetuating historical biases that, really can calcify these systemic issues even further. I'll also say, you're not, no one should sort of feel alone in tackling this problem. Like, there are things you can do, like developing a responsible AI framework, data governance practices that Milissa touched on, developing governance committees, and ask questions like, should we even build this algorithm to begin with? Is this appropriate? But then there are things like, there is legislation coming out in the European Union, early this year, that's looking at algorithmic fairness, accountability, transparency. And then there's a whole other, there's a growth area of algorithmic auditing as like a new frontier of jobs. So, I just don't think anyone should leave this call feeling really overwhelmed that you have to have this problem figured out just yourself as a healthcare-based organization. There is an entire ecosystem happening in the background that involves everything from, you know, government regulation to, if you're working with a technology vendor that's designing these algorithms for you, they will have some sort of risk mitigation service to also provide, because the technology industry is well aware of this issue.
Absolutely.
I'll put a little, just a statement out. I'm going to speak for other people who are not me, but the ACC, CTA, and DiMe, all three of us would love to have you reach out to us so that we can help you meet the people that you need to meet to be able to do what you're doing. You usually don't need to start by recreating the wheel. You can take someone else's wheel and then see how it adapts to yours, and sometimes scrap parts of it and say, that doesn't work here. We need to think anew. And that's actually the best part, right? When you say, wait, it doesn't fit here. What is our particular need? And then kind of you get going. But so please feel free to reach out to any of those organizations. Let me ask a question that Shanti Ramakrishnan asked, which is, how do you design frameworks? How do you design frameworks when contexts switch or change? Do you just design and iterate? Or is there something else in mind? And Shanti, if you want to tell more and type in more about your question, or even raise your hand in the question answer session, that would be fine too. But maybe can we give a stab and then we can get some more information from Shanti?
Just, I'm happy to start. So I think, yes, building, you know, an iterative process or system that you're working with that allows some form of end user feedback. Like, I think there should be some sort of protocols in place in which, if you are designing a system intended to better the outcome of an individual, that you test that process on the actual individual and provide them an opportunity to provide feedback, which then should then iterate whatever framework or model you're designing. But really, like every step of the analytics lifecycle, which I'm sure Milissa and Carol know, you know, there is an opportunity to ask and question the data, you know, of the objectives of the project sort of being met. Is there accurate representation of the data? You know, are we answering the right question? Is fairness or accountability baked into the entire process? All those types of questions, which I think can be iterated upon.
Yeah, let me just add on to that. I think that's lovely. You know, for us, it's actually built into the very fabric of our name. You know, you need a feedback loop. You have to close the loop. Right. And so we are built to be very transparent. Everything's very explainable. Everything's very auditable. And nothing comes kind of canned. The whole idea is for it to be very agile, right? The whole process as you go through from the very beginning of the data to the features that are built, to the models that are built, to how they're used. We even have a spot in the models where we want feedback on whether or not the user, maybe it's a physician or whomever, I don't agree with this. We need feedback on the results of the models themselves, right? So that we build those feedback loops in. But yeah, I think that the frameworks, they need to be designed to be contextually relevant. And that's something to demand of your vendors. You know, if they come and try to sell you a pre-trained model or something that's kind of a black box, you should run, not walk to the exit. You know, the odds that that thing is not going to be right for the context in which you are now, let alone the one that your business is going to be in a year from now, are pretty high. And you can do real damage by deploying algorithms that don't reflect the context of your data, your patients, and your resources. Yeah.
And if you are one of those companies who is listening to Carolyn going, oh God, I think that's me, that's okay too, because you have a good intent, you're doing good work, but there's a real role for co-development then. Whose question are you answering? Where are those? Where are the needs? And can you engage them in helping you get the right information, the right context, and then how you're looking at the data to be able to do all the things that we've talked about so far. So, you know, it's not too late to start to shift gears and figure out how to do this. You know, Julie points out a great point in the commentary. She says, unfortunately, little funding goes to the CBOs, and health systems tend to be a little more transactional in their interactions for the reasons that you just talked about, Milissa. So I do think one important part of this discussion, and it involves AI and it doesn't yet. And I look at Carol and I go, no, the right answer is it does involve AI and it involves AI now. So I'm trying to reframe myself, but there are so many good interventions that we can make if we really try and get into the community. And there is this very strong level between healthcare organization, institution, payer, an individual that lives not inside healthcare, but in community-based organizations. Someone earlier mentioned, whether it's from places of worship to places of gathering to actual corner stores or medical places. So I think thinking about that area is important. We talk about it a lot when we talk about where should new funding go, but we need frameworks for that area. So I'm getting a little off topic, but I'm going to pull it out because a couple of people are interested in this area, which is, what does data from there look like? Can we paint a picture? Data from the community-based organizations, how are we going to build a framework in there so it's not every single one is separate? Is that something we can do such that we can use algorithms and collect data and develop systems? It's a tough question, whoever wants it first. But.
Yeah, I'll start. I think that this, I hope that this gains a lot of momentum. And in particular, I'm optimistic about that because of the recent kind of reshaping and relaunching of the CMS Innovation Center strategy, where there was a huge emphasis on health equity and promotion of health equity in all things as a deep foundational pillar. There was also greater emphasis on trying to involve more communities and healthcare organizations and agencies where there are beneficiaries and patients that experience a lot of health inequity and health disparities, and trying to make it easier for them to become part of the whole value-based movement. And because of that, I think that there's going to be more investment in that in terms of money to get things rolling, and that's going to be important. And when it comes to data, I think it's important that we think about not only the data that we have, but the data that we can create. So maybe it doesn't exist yet, because I think that if we all know anything, is that with our new technologies, we now have the ability to create more data than we could possibly know what to do with and handle. So let's create some more data and have it be driven by expert knowledge of the things that we know that matter, and then start to gather that and embed some feedback loops so that we can learn what's working and for whom, and to become a true learning health system so that we iterate, much more rapidly than we might in an older, inquiry paradigm of, randomized clinical trials and all of that. This isn't that. This is about learning frameworks, so I'm very optimistic here.
A couple other thoughts that are coming in from the audience. So Ravi, thank you. Ravi's commenting on med school loans and the financial pressures on doctors. He recognizes that it's off topic, let's mention it. I'm going to extend that a little bit and just say, I think the financial pressures, however, on producing the number of blanks you've performed, the number of patients you've seen, rather than the quality of that, is a direction that we are still moving in. It is going slowly, but we still do recognize it, and we're focused on that as a medical profession. So I think it's an important area. Amy wants to have a whole discussion, but we'll bring it up, about how patient address factors into algorithmic bias. Census tract and block info will incorporate info that tells more impactful info about the patient than the individual's characteristics. So is there census information, zip code information that we can make sure that we're including, and see how impactful that is and how an individual does? There was somebody else earlier who also commented on the environment rather than the individual, and I'm trying to go back to that. But I think that was no, it was different. I'm going to give you both though. So one is zip code, address, environment, where you come from. How do we account for that? Are we doing it? I think the answer is a yes, we are starting to, if we're not already doing it. But and then the second is, can we talk a little bit about copays related to algorithmic bias, and if AI can ever level that playing field? So let's start with zip code. We'll go to copay.
I can give you a really interesting example using zip code, some work that we did. So people are familiar with the idea of a food desert, right? What an interesting variation on that, there's this idea of a food swamp. And you can just imagine what it might be, just all of the different, the nutritional value that is within, 3-mile radius of you is pretty low. And so we were able, using the zip code in which a particular person lived, we scraped information from Yelp. And so there was a really interesting paper that talked about the presence of different types of So it was well published, but then the data sources we actually had to go and grab from things that we could get from Yelp. And we were able to calculate a feature or a variable called a food swamp. And in this particular population, it actually rose for certain individuals to be a fairly high risk factor. So it's just an example of getting creative, with some of the data that actually is available out there. So that one was very fun.
It also gets to a point where you are very comfortable, Melissa's comfortable, with letting the data guide you. We have yet as clinicians we let data guide us in lots of other ways, but there's usually a theory first and then data guides us. And the idea that we look at data, see what's coming at us, and then see if we can build a theory around us in a way. I think there's a combination of both that are important.
Yeah, it was a combination of both. It wasn't a random act of kind of data integration. It really was theory led. They're really elegant paper published on food swamps, and so that was the piece. But the question was, it was in a paper, and in that way only in theory. Could you actually do it with real world data? And that was kind of the hat trick. And so it was very exciting to actually see it come to life.
And I think looking at zip plus 4 too, right? It's like, I mean, you to get to the point where you're too small, but you also, some people's universe is very small, right? And so I think that there's ways to look at zip code, and then there's times zip 4, and then there's the especially in transient populations, where we know a lot of time the movement isn't significant.
Right.
It's a lot of addresses, right? And so
Right.
I like the zip code. I've really been chewing on the copay ask because I think that I was trying to think, so much of what you pay in a copay is driven by what insurance plan your employer may have purchased. Or here's another one. I think I'm a healthy 25-year-old and I'm going to get the highest, cheapest plan. So my copays are off the roof, right? So it's very, I'm hesitant about copay information. I think you can learn things from it. I would want to spend a lot of time learning from it before understanding what it tells me, if that makes sense. That's probably very vague, but
no, I think that makes a lot of sense. I see Jennifer is signaling, as we do in Zoom through the chat back here. It's kind of like waving arms signaling. So let me take a minute to just wrap us a little bit, which is, first of all, a huge thank you. And Jennifer will give the official thank yous. But I think we started with talking about the concept of AI and that as algorithmic care even, right? Before we even get to AI. How that is here and we need to think about it. How our data matters all the way through, from what it is that the context is, who the patients are, what the population is, and how we're building it, to checking what we see as our short or long-term outcomes or our cohorts, and recognizing it's not a judgment, but there will be biases, there will be things we can improve upon, and being willing to iterate and not letting that process slow us down such that we don't start. So we go ahead and start. We start with a clear question, and we reach out to organizations who are willing to help us or connect us with others who may have done something similar, so we don't feel alone. And when we think about the equity portion of this, if we do all of that correctly, we will still likely have some bias, but we will be willing to go back there, as Sarah says, and reorganize that and think about it again. And then eventually with that iterative process, we'll be able to solve for some of this. So I think this was just such a beautiful story that all of you were able to tell. Jennifer, let me turn this back over to you, and thank you for letting me be here with these wonderful people.
My goodness, thank you, all of you. This has been absolutely phenomenal, a truly world-class panel. I think, Amy, to pile on to your very thoughtful remarks in closing, ladies, you've made the point that we have access to enormous data sets. You've made the point that we have the methodologies, we have the best practices in order to be able to thoughtfully and meaningfully address bias in AI, and to be looking at feedback loops to check ourselves and recheck ourselves as our knowledge improves, that the partners and the experts exist to help our clinical colleagues to do this really well. and the incentives exist. There is absolutely no reason for us not to be doing this now. And I think, Carol, you opened with that. I think we should close for that. This is not something that we're unable to do. This is not something that we can't find the data or the methods or the partners. We cannot be willfully ignorant anymore. We have to move. This was absolutely extraordinary, ladies. On behalf of the Digital Medicine Society, on behalf of our colleagues at CTA, this was absolutely tremendous. And for folks on the line who may not have signed up yet, this extraordinary series continues next week. So I will be joined by Aaron Martin at Providence St. Joseph, Han Pak, CMO of Samsung, David Rue, CMO of Microsoft, and Drew Schiller, CEO of Validic, to continue the conversation. Thank you, ladies. This was absolutely extraordinary. Thank you, everyone who listened. I think there were some strong calls to action there. The time to act is now, and I look forward to doing that together as a field. Thank you so much, everyone, for your time today. Thank you, Milissa, Sarah, Carol, and Amy. Grateful for all of you.
Thank you all.
Thank you so much.
Thanks so much.
Take care. Bye-bye.